Good afternoon, everyone. For those of you who don't know me, my name is Ryan Abe. I'm one of the chief residents, and I have the pleasure today of introducing our grand round speaker, Dr. Shireesha Dhanireddy. Dr. Dhanireddy is the triple board certified in internal medicine, infectious disease, and addiction medicine. She's a professor of medicine in the Division of Infectious Diseases and a clinician scholar at Harborview. She also serves as the medical director of the Madison Clinic and the Infectious Disease and Travel Clinic at Harborview. She's a co-author of the Infectious Disease Society of America guidelines for vaccination of the immunocompromised host, as well as the co-chair of the guidelines for management of opportunistic infections, people with HIV. So she's speaking with us today about vaccines and immunocompromised hosts. So without further ado, I will turn the stage over to Dr. Dhanireddy. As a reminder, please post your questions in the chat and I will pose them to our speaker at the end of the presentation. Thank you.
Great. Thank you so much, Ryan, for that nice introduction. It's a pleasure to be here today to talk about vaccines, always a timely topic. This is going to be focused on immunocompromised host. I don't have any disclosures except that as an infectious disease provider, I am very pro-vaccine. Today, we'll be just talking generally about a little bit about background, how I got into my interest in vaccines, but then going on to general principles of vaccinating immunocompromised hosts, some vaccine-specific considerations, and then I'll end with COVID-19 vaccines, in particular in immunocompromised hosts. This is not going to be a comprehensive talk about all the vaccines and the vaccine recommendations for all IC hosts. There are societal guidelines and ACIP, Advisory Committee for Immunization Practice Guidelines. What I really want to focus on today are the principles and considerations that are unique to immunocompromised patients as opposed to the general population. So just a little bit about kind of how I started. I'll just kind of fast forward here, but how I started my journey into the world of vaccines. After completing infectious disease fellowship, I was fortunate enough to work with David Spock in clinic, who kindly asked if I would be interested in working on the development of the Infectious Disease Society of America guidelines for vaccinating immunocompromised hosts, and specifically the HIV section. That led to further opportunities. So those guidelines were published in 2013. And around that same time, I should have put Dr. Wes Van Voorhees. He was the one that invited me to work with him on the opportunistic guideline development of geographic opportunistic infections. But that kind of was an entry point in working on these guidelines and led to me working on the vaccine guidelines sections for people with HIV. And I eventually became lead of that section. And then most recently this year, Dr. King Holmes passed the torch to me to become co-chair of that as well. So the point of this is that this was not a field that I thought, would be a passion for me or some area of scholarly focus, but you never know. And so when you have these opportunities, it's really important to explore them. It could have been that I said, you know what, I liked working on those guidelines and I'm not going to pursue it further. But in fact, I was interested and continue to work on them today. All right, so general principles of immunization of IC hosts. First, I wanted to just go over some language and definition of what an immunocompromised hosts are. I think we think about it in our, specialized centers that we have at the University of Washington, like our transplant populations, and that maybe, our general internist colleagues are not the ones seeing these patients, but I would say that everyone has immunocompromised hosts that they're taking care of on their panel. Recently had a colleague who works at the Shoreline Neighborhood Clinic who has actually a panel of many solid organ transplant patients who are years out from their transplant, but still on immunosuppressive therapy. So we all should be aware of these differences in immunization guidelines. Also wanted to briefly touch on the process of FDA approval to recommendation and how that can be different for immunocompromised hosts. And there can be a delay given the paucity of data for vaccines, at least initially in immunocompromised hosts. And then I wanted to talk a little bit about level of immunosuppression, as that can have a big impact on what vaccines are okay and what are not, and then timing as relates to not just their level of immunosuppression, but pre-post-transplant. So in terms of definition, the CDC actually in their guidance calls it altered immune competence, and it's sort of synonymous with immunosuppression or immunodeficiency or immunocompromised. And I categorize that as primary or secondary. We see a lot of people, many of whom have secondary immunocompromising conditions, but we also have a primary immunodeficiency clinic that actually Dr. Lyles used to head at the University of Washington Montlake. So those disorders are inherited cellular, humoral, or complement deficiency, or a combination of those. Secondary, HIV is one of the big ones that I obviously see in my practice, but we also have our close relationship with the Fred Hutch, and so see a lot of patients with malignancies and iatrogenic immunodeficiency, as well as transplant patients. But that term can also be fairly broad. We know that patients with CKD on end-stage or with end-stage renal disease on hemodialysis are also relatively immunocompromised compared to the general population. And then we know that the severity of this altered immune competence can affect both the efficacy and even potentially the safety of vaccines. So really knowing that information about the patient is really important as we think about how well these vaccines work and if there are going to be any potential negative consequences of vaccination. So this I just wanted to show you because we in the COVID era have seen a very accelerated phase of vaccine development and clinical trials and ultimately recommendations. But normally this is a little bit stretched out of a process, not because the science was rushed at all with COVID or the science is slower with other things. It's just that with a global pandemic, all hands were on deck, and a lot of this research was being done in collaboration and in tandem with, so some of these trials were overlapping each other. But normally what we do is we have sort of the preclinical phases where there's basic science discovery and preclinical studies, and then we have our phase 1, 2, and 3 trials in humans. And then based on that data, there's an FDA review. And then there's an approval of that vaccine, and then an advisory committee on immunization practices review where a panel meets and gives a recommendation. That recommendation then has to be formally approved by the CDC director to become a formal recommendation that's usually published online or in MMWR. And then even after that approval and recommendation, there is a phase 4 where there's safety and monitoring for any post-marketing, any adverse effects that may come about that we may find a signal for. And that's definitely been the case with COVID vaccines, as there have been a signal for instance, myocarditis that was not initially picked up in the trials. This is from ACIP, and it is the guidelines for specifically for certain conditions. And I know the print is a little bit small, but I wanted to kind of go over a little bit what this is. So immunocompromised is up here, and then HIV is called out separately. But what you can see is that there, as opposed to some general population where it may be recommended, there are some not recommended, and then the gray boxes where there is an absence of recommendation. This is actually already outdated because we have a new recommendation that I'll go through for recombinant Zoster vaccine. So as I mentioned, there's often a lack of data for efficacy and safety in immunocompromised hosts, and often those studies, because they're excluded from the initial trials to determine efficacy and safety. So if you're a vaccine manufacturer and you're trying to show your vaccine works, you probably don't want to include patients who have immunodeficiency because you want this vaccine to get approved. And so often those patients are not included. For instance, in the FDA approval for the recombinant Zoster vaccine, the ZOE studies, immunocompromised patients were excluded. And so that's why there was a lack of recommendation initially for Zoster vaccine. We know that, for instance, in Zoster vaccine, the problem with excluding these patients is that the incidence of herpes zoster in immunocompromised patients is higher. So, for instance, in patients with HIV, there is a higher incidence of herpes zoster regardless of age. So we know that in the general population with age, that there's an increased incident herpes zoster, but you can see here that in both male and female people with HIV, that there's a higher incidence, even in your 20s, 30s, and 40s and 50s, and not just your 60s and 70s. So this is what I was pointing to, the original studies that showed this dramatic effect of recombinant zoster vaccine for prevention of initial episode or first episode of zoster in immunocompetent patients over 50. And you saw these incredible efficacy of this vaccine, again, not with immunocompromised hosts though. This was published in 2015. Subsequently, we have had data that has come out in immunocompromised hosts. So this is actually a large study that was published in JAMA with the recombinant zoster vaccine given to nearly 1,850 patients. And there were 2 doses of recombinant zoster vaccine versus placebo, and they followed them for 21 months. And they found that there was a significant reduction in incident herpes zoster in these transplant patients who received the recombinant zoster vaccine. So 30 per 1,000 person years in the vaccine group versus 94 per 1,000 person years. And this is one of the key trials that has led to a more recent recommendation that I'll talk about some more. So the other key important topic to discuss is the level of immunosuppression. So not all immunocompromised patients are at the same level of risk or degree of immunosuppression. So when we think about immunosuppression, I like to divide it out into high-level immunosuppression versus low-level immunosuppression. And this is relevant when we're talking about, for instance, the COVID vaccine, where that immunocompromised host was considered someone who is moderately to severely immunosuppressed. So the examples of those are people with primary immunodeficiency disorder, people who are actively receiving chemotherapy or early during solid organ transplant. And then for those with HIV, people who have CD4 counts less than 200. And in terms of steroid therapy, there are specific criteria. So if you're greater than 20 milligrams a day of steroids for more than 2 weeks, so excluding these people that are just on short bursts, maybe for their COPD for 5 days, but really on more chronic high-level steroids, then that's considered a higher level immunosuppression. There's certain biologics that are also included, as well as stem cell transplant patients. Low-level immunosuppression is sort of people on immunosuppressive therapy, but who don't essentially meet these high-level immunosuppression criteria. So lower doses of steroids, less immunosuppressive immunomodulatory therapy, and then people with HIV who have higher CD4 counts, essentially. So just to kind of show you a little bit clinically, this is from data that looking at antibody response to mRNA vaccine by immunocompromising condition. And you can see cancer patients, it was variable, and that's because different chemotherapy agents and different types of malignancies do lead to a variability in level of immunosuppression. Hemodialysis patients who are relatively immunocompromised as well, but seem to have higher antibody responses when it came to response to COVID vaccine. But you can see here that organ transplant therapy, organ transplant patient recipients do have a much lower antibody response, and that speaks to their higher level of immunosuppression. So, and then, you know, as you can see, the variability in immunosuppressive therapy. And then healthy controls were really above the 95 to 100%, as we know with the efficacy of these mRNA vaccines. So the other consideration that is different than the general population is timing of vaccine. So as we all know from the ACIP schedule, it really goes by age most of the time. So once you hit a certain age, then you'll just get the vaccine, and there's not really any other decision-making point. For people who are immunosuppressed, we really want to think about when is the best time, not only to provide the optimal protection against an infection, but also when is their immune system best to respond to that vaccine. So do you want to give it early to provide protection against something, or do you want to wait to wait for their immunosuppression to drop, waiting in the post-transplant period? For instance, if you provide a vaccine too early to someone and then they get myeloablation, then you've essentially wiped out that immunity. And so that's really hasn't done anything for the patient. And in that situation, you would want to wait potentially for vaccinating post-transplant once they've had some engraftment and are able to generate an immune response. So for solid organ transplant patients, there are some guidance in the 2013 Immuno-Compromised host guidance, as well as in the ACIP guidance from the CDC. And then there was more recently a position paper about how to manage vaccines in the solid organ transplant recipients. In these guidelines, as with all guidelines, prior to transplantation, it's really important to review the vaccination record and provide appropriate vaccines and make sure that they've had their routine immunizations. One of the important things to note, though, is that just prior to transplantation, you want to avoid live vaccines as the concern for safety in those patients. And they usually stop giving live vaccines at least 4 weeks prior to transplantation. And then for inactivated vaccines, at least 2 weeks prior to transplantation. For post-transplant timing of vaccines, most guidelines say at least 3 to 6 months post-transplant. And that's really because that heavy period of immunosuppression right after transplant, so they're not likely to respond. Some guidance deviates and says for influenza, particularly during an influenza season, that you could recommend 1 month post-transplant, as early as 1 month post-transplant. But that is variable. I think our institution uses 3 months post-transplantation for even inactivated vaccines. For hematopoietic stem cell transplant patients, pre-transplant timing. So it's important, as I mentioned, it's important to try to review that pre-transplant. But again, if they're getting a heavy conditioning regimen, it's unclear how much really they'll benefit from vaccines pre-transplant. Post-transplant is another, the timing, again, similar to solid organ transplant patients, that early post-transplant period, there may not be a great response given the level of immunosuppression during that period. And then I wanted to say a little bit about the donor in this situation. So just like with solid organ transplant patients, we'd want to review the vaccination record and appropriate vaccines are given. This is just a sample. This is a study that was published looking at actually with some local authors, Steve Pergam and Catherine Liu and Helen Chu were part of the study, showing that amongst their patients that there was very low immunity to measles and mumps. And so you can see that the negative is in the dark green and the equivocal, which presumed negative, is in the yellow. And you can see that there was up to about 25% of patients who in their cohort of cancer and transplant patients who had low immunity to measles. And so really important to note that even pre-transplant that we're seeing potential gaps in protection for those patients. No live vaccines, similar to the SOT population, where you don't want to do that within 4 weeks of conditioning. And then no inactivated vaccines within 2 weeks of conditioning. Post-transplant, again, some guidance says influenza may be given as early as 1 month later, but most, and I think our institution uses 3 months just because, again, during that heavy period of immunosuppression. There have been some small studies looking at donor and vaccinating donors prior to transplant. And for instance, with PCV7 at the time, and evaluating immune responses in the recipient. And essentially, those small studies didn't really show a huge difference, especially if the recipient received a complete series of vaccinations on their own. So that the donor vaccination status didn't really influence it that much. Also, there's some ethical concerns about vaccinating a donor purely for the health of the recipient. So currently, there are no recommendations for donor vaccinations prior to stem cell transplant in the population. Then I wanted to just talk about some special considerations in immunocompromised hosts that are a little bit different than our general population. And so I'll go through some of these in particular, and we can talk about them individually. So adjuvanted vaccines, we have a number of adjuvanted vaccines. So an adjuvant essentially is something that really boosts the immune response to an antigen. It's in particular to inactivated, so not live vaccines where you really want to enhance the immune response to it. So some examples of some more novel adjuvants that have come out recently are, for instance, in Heplisab, the recombinant adjuvanted hepatitis B vaccine that we know is highly efficacious. The TLR, it uses an adjuvant that's a TLR9 agonist to enhance the immune response to the vaccine. Shingrix, another more recent vaccine, is a recombinant adjuvanted herpes zoster vaccine that is a novel adjuvant that had not been used in other vaccines, that is from an extract from a tree native to Chile that is very much boosts the immune response. And as I showed you in that slide from the Zoe trials looking at efficacy, so near 100% efficacy of preventing incident herpes zoster. And then I'll remind you that the live vaccine that is no longer being produced for herpes zoster had a pretty good efficacy, but nowhere near the efficacy of Shingrix. So that Zostavax, for instance, was just a little over 50% effective at preventing incident herpes zoster. So clearly these adjuvanted vaccines do work. One of the concerns, though, with adjuvanted vaccines and we're getting more data for the use of adjuvanted vaccines in transplant populations and heavily immunosuppressed people, but one of the concerns particularly in solid organ transplant is concern for rejection. There was a study that looked at adjuvanted influenza vaccine and solid organ transplant recipients. And didn't really show a rejection, but one of the concerns in that study, which was about 490 patients, was that they selected out patients that were relatively low risk for rejection. And so there still is concern if you have a non-adjuvanted vaccine that it would be preferred in those solid organ transplant patients. And for stem cell transplant patients, there is a concern for GVHD as well. So however, as I mentioned, we are getting more data with adjuvanted vaccines in these immunocompromised hosts. Another strategy is high-dose vaccination. So this is actually from a study published in New England Journal of Medicine in 2014. Not immunocompromised hosts, except they're elderly, so relatively immunocompromised with immune senescence, but high dose flu in people 65 and over. And so this study included over 32,000 patients who were randomized to high dose versus standard dose and looked at laboratory confirmed influenza in the seasons of 2011 to 2012 and 2012 to 2013. It was a randomized controlled trial, and you can see that there was a reduction in incidence of laboratory confirmed influenza, about a 24% relative decrease. And so for our patients who are 65 and older, this is an option for using high dose flu vaccine. It has been additionally studied in more immunocompromised patients as well. And there was a small study, a randomized controlled trial in hematopoietic stem cell transplant recipients, only 44 patients, that did show some promising results. And an RCT is actually now underway, but those results are still pending, looking at high dose influenza. Not only can we use a high dose strategy, but we can also give extra doses. And so, for instance, in people with HIV, the example that I'm going to give is Hepatitis B vaccine. So we know in people with HIV that there are lower response rates to hepatitis B in terms of seroconversion or a seroresponse in patients with HIV, and that's anywhere from 18 to 71%, and that can depend on their CD4 count and their viral load. There was a study that looked at Hep B responses in people who, in a military cohort that essentially had 1,800 patients, and 440 of them actually developed incident HIV in that study, in the natural history study. Some had been vaccinated before their HIV diagnosis, and some had been vaccinated after. And what they found is if you're vaccinated before your HIV diagnosis, essentially had a much better immunologic response than waiting until after your HIV diagnosis. Obviously, that's not practical in most patients, but we do want to encourage Hep B vaccination in general, so that even if you were diagnosed with HIV, you would have a better response. Nina Kim did a really nice study looking at predictors of non-response. And one of the things was if you've ever had a CD4 count, so CD4 count nadir less than 100 or less than 200, then your chance of vaccine response was quite a bit lower than if you had a CD4 count that was maintained above 200. So the strategies for additional dosing, there's actually 2 randomized controlled trials of 4-dose double dose. So not only giving an extra dose, but a double dose of hepatitis B vaccine. This was prior to Heplisav. So this was the standard recombinant vaccines. And so giving 4 doses double dose versus 3 doses of standard doses. And what we see here, and when we look at protective titers greater than 10 versus high level response, and this is up to 28 weeks after the study, you can see that in the white bar, that's the standard dose regimen versus the shaded bars, which are the higher dose regimens. And so there, people did have a higher response. So the recommendations in the OI guidelines are actually to consider for initial vaccination schedule, or in patients who are initially non-responders, to try that double dose, high dose strategy. What about the use of live vaccines? So this has always been a concern in patients who are immunocompromised and concerned for maybe vaccine-induced disease. So the current guidance for instance, for transplant patients is that measles vaccine can be given 2 years post-transplant if they have no active GVHD and at least a year off immunosuppressive therapy. And it's a 2-dose series. Unlike a booster, essentially you're restarting because we assume that they've had, particularly if they've had a mild ablative transplant, that they're really not going to have any lasting or historical immunity from prior to the transplant. And you can see here the probability of being seropositive to measles in time after transplantation if you've had a previous vaccination, and you can see that that immunity drops considerably over time. And so, as we know, we've had some measles outbreaks, so really important to consider when it's safe to do so to vaccinate transplant patients against measles. But there has been one more recent report of vaccine-derived disease that was just published this year in August. it's a case report of a 22-year-old gentleman who was pre-B cell ALL status post a myeloablative allogeneic transplant 4 years prior to presentation. He did have GVHD, but he had been off of all iatrogenic immunosuppression on day 1135. So he was appropriately off. 73 days after his immunosuppression was stopped, he received the MMR vaccine because of concern of a local outbreak in his community. 9 days post-vaccine, developed fever to 40, cough, sore throat, lymphadenopathy, and then developed a faint rash and was RNA positive for measles. So I bring this up because we think about risks and benefits all the time with vaccination. And in this situation, because of the outbreak, felt important to pursue vaccination. And that is actually in a position paper that was published by some of our local docs here, Steve Pergam, Jeff Duchin, and Jan England, that it's okay to give it earlier if you are concerned and in an outbreak situation. But again, not without risk for some of these live vaccines. The other thing to consider is expanded age recommendations. So for instance, I'm going to go over 2 different vaccines where there's expanded age recommendations. So we think about, as I mentioned in shingles, for shingles or herpes zoster, we think about patients specifically over 50 getting a higher incident rates of herpes zoster. But we know in immunocompromised hosts, like I mentioned with HIV, that can happen at any age. So why wait for the general population age 50? So just last month, just a few weeks ago, the ACIP voted unanimously to recommend recombinant zoster vaccine to adults 19 and over who are or will be immunosuppressed due to disease or therapy. So as I showed you before, there was a blank recommendation. There was absence of recommendation in this population because of the lack of initial data from when that recommendation came about before. But now, since we have additional data, particularly in transplant patients, that the recommendation is now to give 2 doses for immunocompromised patients or people who are about to be immunocompromised starting age 19 and above. This is not yet a formal recommendation because it still has to be signed off on by the CDC director, which should be soon. So that's why there hasn't been an official release, which is what usually happens, where they publish it in MMWR as a new recommendation. But that should be coming out before the end of the year, and this is a big practice changer, definitely for our Madison clinic folks where I work, where we're going to be giving a lot more zoster vaccine. The other situation where we see some different guidelines for people with immunocompromising conditions or maybe other risk factors is with pneumococcal disease. Again, this was voted on by ACIP, so the advisory committee has yet to receive the formal stamp of approval from the CDC director, but we expect that soon. So you all probably know that the conjugate 20-valent vaccine was recently, earlier this year, FDA approved. And ACIP met to talk about how to incorporate that into our existing guidelines for the general population, but also for immunocompromised hosts. So the ACIP recommended that PCV20 or PCV15 be given to all individuals age 65 or older who have not previously received a conjugate vaccine, or if it is unknown. For people with certain risk factors for increased risk of invasive pneumococcal disease, so that's not just people with HIV, but other immunocompromising conditions, and then a host of other factors like chronic lung disease, chronic heart disease, chronic liver disease, smokers, diabetics, people with alcohol use disorder. You could argue that's pretty much everyone we see at UW Medicine. So for those individuals, conjugate 20-valent vaccine is also going to be recommended for 19 to 64, so before that 65-year-old recommendation. Again, not formalized yet, but we will be seeing this recommendation come out likely before the end of the year. The other thing to consider is cocoon vaccination strategies, and this is a cocoon or ring vaccination is a term or terms that have been brought up recently with COVID, but this is actually something that has been around for a while, particularly when talking about newborns and prevention of vaccine preventable diseases. So our newborns can't necessarily get some of these vaccines, but we can, for instance, influenza vaccine, so less than 6 months of age, they can't get that, but we can provide a ring or a cocoon of protection by getting everyone else in the household and close contacts to be vaccinated to protect that newborn. Similarly, for our patients who are immunocompromised, who may not be able to get a live vaccine or to who may not mount an adequate immune response, the way to be able to protect them is that everyone around them get vaccinated, so that they have that indirect benefit. If everyone around them is protected and can't get COVID, for instance, then they're not going to get COVID. This I'll just skip over, but it really shows, this is actually with relation to newborns that, and it's a cost analysis that if you do a cocoon strategy, that you can actually decrease costs for vaccination for vaccination rather than just blanket vaccinating everyone. All right, so vaccination of household contacts, some things that similar to the cocoon strategy, we want to make sure that everyone has had their routine vaccinations. Some caution for some of these live vaccines. So there are some guidelines to avoid use of live influenza vaccine and other live vaccines within 2 months of transplant or if highly immunosuppressed. If for people that live with children who may get the live rotavirus vaccine, to not handle their diapers for at least 4 weeks following that vaccine. So just precautions in terms of concern for vaccine related disease and transmission of vaccine related disease. Some live vaccines can be used safely in close contacts. But I do want to point out that there have been cases of transmission, and one case, which is good that we don't use oral polio vaccine anymore, but there have been a smattering of reports in the 2000s of children who were unvaccinated that ended up getting children who were immunocompromised and had a household contact of someone who got the oral polio vaccine, who then developed vaccine-related disease and some even fatal. So it's a good thing that we don't use this anymore, but we do want to be cautious about live vaccine in close contacts, particularly in our heavily immunosuppressed patients. So one other thing that is important to consider is assessing vaccination response in patients who are immunocompromised. We don't necessarily do it for the general population, but we do it for some vaccines, and particularly if there is a correlative immunity that we know about. So for instance, with hepatitis B vaccine, we know that a titer greater than 10 is indicative of immune protection. And so we want to make sure that patients have had an adequate response. And if not, to use alternative strategies, like I mentioned, high dose, double dose, or a different vaccine that's more immunogenic, like Heplisav. Hepatitis A vaccine, also, that's a relatively newer recommendation, particularly with HIV, as we've seen patients who've had waning immunity and breakthrough infections even after vaccination in the past. varicella, and then, as I mentioned, MMR, and that data that showed waning responses, particularly in transplant patients. I do want to call out not COVID-19. We've had a number of requests from patients, and I know many of you have received requests to check antibody responses. We don't have a good correlative immunity for COVID-19 vaccine. We know that it's more complicated than that antibody would tell us. And so the CDC actually statement actually is to not check COVID-19 antibodies in patients, even if they're immunocompromised. There are some niche recommendations, and I just wanted to call out for patients on eculizumab and specific concerns about certain infections. So eculizumab is a monoclonal antibody therapy that's used in very specific situations. So we do have some patients at the U on it, but it confers 1,000 to 2,000-fold increase risk of meningococcal meningitis. So that is a pretty significant risk. And so the recommendations are to immunize both with quadrivalent and MenB vaccines at least 2 weeks prior to eculizumab therapy, and then to repeat that every 5 years while they're on eculizumab. Even despite that immunization, patients remain at increased risk. And so just something to note about this vaccine preventable disease and this particular therapy that does confer higher risk. And then people with HIV, incidence of meningococcal disease is higher than in the general population, 11 to 24-fold higher, particularly in patients with lower CD4 counts. So the recommendations are different than the routine recommendations for patients where we would give a 2-dose series as an adult and that 8 weeks apart and then repeat every 5 years. Okay, so switching to COVID-19 vaccine, I wanted to start by saying, just defining a little bit what an additional dose is versus a booster. As we saw the additional dose recommendation come out in August, and then the booster dose recommendations come out in September. So an additional dose of vaccine is when the initial primary, after an initial primary series, that the person did not have a sufficient response to that vaccine. A booster is when you've had a sufficient initial response, but that response wanes over time. And so we give boosters for other things, for instance, tetanus. But the additional dose is really what I want to mention in relation to immunocompromised hosts. The data that led to that recommendation is really in solid organ transplant patients, and this was published in the New England Journal of Medicine, that showed earlier this year that showed despite a 2-dose mRNA vaccine, which, as we know, are highly effective in the general population, in SOT patient recipients, what we saw is that there was still a really relatively low response rate, roughly around 40%, but that was significantly improved if a month later you gave that 3rd dose. So essentially for immunocompromised patients, giving 3 doses is equivalent, or not even equivalent really, to giving 2 doses in the general population. And so for the recommendations that came out in August are that in patients who are moderate to severely immunocompromised, really extrapolating from that SOT population, so those are moderately to arguably more severely immunocompromised, that you would give the initial mRNA series plus an additional dose 28 days after the 2nd dose, and preferably the same mRNA vaccine. If not available, okay to give either product. And then they more recently came out and said, well, these people still need a booster because they're probably going to have waning immunity over time. And so that would mean a 4th dose given 6 months after the 3rd dose. Another point to make is that for patients who have had a transplant since their initial COVID vaccination, if you've had an ablative transplant, a high-level immunosuppression, you're going to probably need to be revaccinated post-transplant. And that's again with the 3 doses and then a 4th dose. So the people who are stem cell transplant patients or solid organ transplant patients may be receiving way more than 3 doses, depending on the timing of their transplant. If they received a Janssen J&J vaccine initially, then you can get an additional J&J vaccine 2 months later, or a Pfizer vaccine, or a half-dose Moderna. So I know people have had issue with this recommendation, because if you've received a J&J, it seems like you're getting a lot less vaccine than if you got an initial mRNA series. Even though the CDC guidance is fairly broad to give any one of these, for my immunocompromised patients, I am preferably giving a full dose Pfizer instead of giving the other vaccines. Again, do not check antibody titers to assess response to determine eligibility for that 3rd dose. Just give it. Just give that 3rd dose for our patients who meet that definition of moderate to severe immunocompromised. And then if possible, there was some really nice rheumatology American College of Rheumatology guidelines that came out in February that talked about timing of mRNA vaccines or COVID vaccines in relation to their immunosuppression. But in general, what we want to try to do is complete the series prior to immunosuppression, and that's not always possible. Of course, with our immunocompromised patients and COVID, we want that cocoon of protection, but given that these patients have blunted responses, even with multiple doses of vaccine, and we're still seeing high-level transmission in our area, to still mask and practice physical distancing. So essentially, the vaccine doesn't change a whole lot for us right now, and that because of our high-level transmission in our area. So just wanted to review some summary points and leave some time for questions. So immunocompromised hosts are obviously at increased risk for vaccine-preventable diseases. ACIP and society guidance may differ for immunocompromised hosts than the general population because of some of these issues regarding timing and safety. Consider optimal timing for immunization and think about kind of where they are and their level of immunosuppression and how well they might respond, but also capturing that they may be at increased risk. Responses to vaccine are often blunted in patients with immunocompromising conditions, and then encourage cocoon strategies for additional protection for all of our patients in their close family contacts and household members. I wanted to just reference the CDC guidelines, but I have my references throughout the slides, and then an acknowledgement to Steve Pergam, who's done a lot of this work in stem cell transplant patients and who kindly reviewed my slides. Thank you all.
Thank you so much for that fantastic presentation. We have a lot of questions in the chat that I'll start to pose to you, Dr. Dhanireddy. The first one being, in solid organ transplant patients, do you have any data that the responses wane faster than the populations, thinking about giving that 3rd or that booster dose even sooner than the 6 months, or even a higher dose or a different dose in general?
You know, that's a really good question. I don't know the answer to that question. We know that 3rd dose doesn't confer that same level of protection already that we see in the general population. As you saw, it was more around the order of 70%. And so, the recommendation currently is 6 months. I'm not seeing any different, and I would ask Ajit, I don't know if Ajit or Bob Rakita, our SOT, my SOT colleagues have any other thoughts about that. But currently it's a 6-month recommendation.
Great. Another question, and I can ask those folks to put in the chat if they have any thoughts or knowledge about that. Any pitfalls to using antibody titers as surrogate markers for immunity, and thinking more about kind of like those T-cell based assays instead?
Yeah, no, that's a great point. I think it's definitely a pitfall because it doesn't give us a complete picture. And for instance, you know, with COVID, for instance, it doesn't give us a complete picture, but there are other things too, like herpes zoster, where we don't check titers either. We do for varicella, but not for herpes zoster. And so where we know that there's more of a T cell mediated response. I don't know, those are not done usually commercially. And I know Conrad is very interested in immune responses and has a lab about that. So I would defer to you, Conrad. I don't think that there are many commercially available for most of our infections to look at T cell responses rather than just our humoral responses.
A couple of questions came through about sort of vaccination response in the elderly, and so thinking about immunosenescence. Should we regard older patients over the age of 65 or an 80-year-old, for example, as somewhat immunosuppressed, and how do we think about that?
Yeah, no, that's a great question. And I think that's one of and just bring it back to COVID. That's why we do have those recommendations. The strongest data was actually in our older individuals, and there's really not a lot of data in younger individuals, but there was actually for nursing home residents, it was published in the MMWR just last 2 months ago or so, looking at rates of readmissions or admissions due to COVID in patients who are nursing home residents who are elderly, that there was an increase over time. Some of that probably had to do with Delta, but that also had to do with waning immune responses to their initial vaccination, which was in January or so for most of these individuals. So we do know that there are waning responses.
Mm-hmm. And just a comment, Dr. Lyles in the chat was talking about sort of developing and validating T cell based assays, thinking about things like IGRA for TB, but still more work to be done with that. Another question that came up is there any recent work that talks about correlative immunity with COVID vaccine? And you spoke a little bit about this already, but how we're counseling patients who've gotten the mRNA vaccine and who are immunocompromised.
Yeah, so what I'm doing for my patients, at least that are immunocompromised, who've gotten the COVID vaccine, is to still encourage, physical distancing, masking, as if presuming that they may not have had a good response to vaccination, even with that third dose. But I'm not doing any testing. All of that is not is more research based at this point, but there's not commercial assays that I know of that we would look for those more T cell mediated responses to the vaccine.
Right. Another question that came through was do you have any comments about patients who've undergone splenectomy? Is there any literature out there about how do we think about those patients and their immunocompromised status?
Yeah, so I could do a whole other section about that, and I wanted to sort of hit the more highlights, but patients who post splenectomy do have, are more at risk for encapsulated organisms. So pneumococcal vaccination is really important. And so that asplenic patients are going to fit into this new recommendation for PCV20 to get it as 19 through, whatever age is to get the PCV20 for sure. Also Neisseria meningitidis to get the meningococcal vaccine as well. Those patients are at higher risk. There's also an issue with timing for splenectomy. Optimally, if it's an elective splenectomy, you want to do it prior to at least 2 weeks prior to the splenectomy to try to get a good response. But if it's traumatic, we can't always do that. But ideally it would be done pre-splenectomy.
Going back to your comments about patients with HIV, you mentioned something about CD4 count being around 400 or less. Are we considering all patients with HIV severely immunocompromised regardless of their CD4 count, or how is that 400 sort of threshold arrived at?
Yeah, so for people with HIV, I'm not considering everyone with HIV moderate to severely immunocompromised. Many of our patients in Madison Clinic have near normal CD4 counts and are undetectable. So patients who have a CD4 count less than 200 or who are not virologically suppressed, those are the patients where I would consider them at higher risk. And I think specifically with regards to COVID, for instance, that's who I would do the 3-dose series rather than the 2-dose series.
Perfect. And the last question that I see here is just about the mRNA technology for vaccines, and has there been any research looking into using that same technology to produce flu vaccines in the future on the horizon, since technology is not actually new, but we're only really see it with their COVID vaccine so far?
I think given the efficacy of these vaccines, there is a lot of interest in development of other vaccines. And this is something that Anna Wald is probably more knowledgeable about, but I know that there's interest in using it for herpes virus, herpes simplex, for instance, and to develop an mRNA vaccine. So I think we're going to see this as another strategy and for vaccines to get really more potent vaccines, much more effective vaccines.
That's great. Exciting times. Happy to take other questions in the chat. We have about 5 minutes left until we're at the end of our time. But otherwise, Dr. Dhanireddy, thank you so much for such a fantastic presentation and really exciting things happening in the ID world.
As always, it's always exciting an ID. Thank you so much.
Thank you. Happy afternoon, everyone.